Okay, hello. Are we ready to go? Okay, so I'm Jeein Yoon. I'm one of the psychiatrists on the CAP portal, and I will be talking about addressing sleep in primary care settings today. I just wanted to bring in a couple example cases that we get through the CAP call, and mainly just to help everyone feel comfortable conceptualizing the sleep difficulties that happen in the pediatric setting and how to give just practical advice in terms of behavioral strategies to families. And we'll touch a little bit on what the guidelines are for medication use as an adjunct treatment in this population. Next slide, please. So probably in the past month, we had a phone call from one of the pediatric residents regarding a case of a 3.5-year-old boy with some possible history of trauma that was not really clear to what extent to the primary care physician, but really coming in with a chief complaint of having sleep difficulties and temper tantrums during the daytime. And the resident was really distressed that the mom seemed to be wanting help with sleep difficulties and she can't go to work. That was the main concern, and the resident felt like it was a pressing need that we needed to help this family. So the consult question was very specific in this case. Can we prescribe clonidine to a 3.5-year-old, and what dose would be appropriate? Most of the calls we get are regarding either in terms of sleep, either with teenagers who are struggling with depression or anxiety and having sleep troubles, or on the opposite end of the spectrum, they're very young and providers are feeling a little uncomfortable in terms of how to address the sleep issues. So for insomnia, the definition in pediatrics is usually like having some difficulty in initiating sleep or staying asleep, assuming that they have been given the ample opportunity for sleep, and it results in some kind of daytime functional impairment for the child. In this case, the resident was describing that the child was throwing tantrums because of sleep deprivation and would have a very bad day at school. So the mom was resorting to letting the child sleep in until like noon the next day, missing school. And she's also feeling the effects of that. How can I hold the job down if I'm having to let this child sleep in all day and not being able to send this child to school? Next slide, please. So one thing to take into consideration is that a lot of children, especially young children that are preschool aged or younger, have sleep difficulties, and it's reported as to be up to 20 to 30%. So it's pretty common. It is a developmental process. So as you all know, from infancy to toddlerhood to grade school years and teen years, it's a developmental process. The sleep consolidation happens. You have to regulate their circadian rhythm as well. You have to take into context the family's cultural and environmental background of what's going on. For this case, we kind of paused. I felt like we didn't have enough information. So I did direct the resident to go back and get a little bit more information regarding what the sleep environment was. And also we obtained collateral from a therapist that happened to be working within our department. And we got a lot of valuable information in terms of the co-sleeping environment. This child also had a stepfather figure in the family who was working late night shifts and coming home close to midnight, and he wanted to spend time with this father figure as well. So that was an important factor. And then the trauma history also played into the presentation as well. The mom had lost infant to SIDS a couple years back. So she's very hyper alert with night times and the child falling asleep and constantly checking and on high alert. So next slide, please. I had recommended for the resident to use the BEARS screener for sleep. This is actually freely available in the public domain to download, and we also have it uploaded on our CAP resources as well. The BEARS really stands for bedtime resistance, excessive daytime sleepiness, awakenings at night, regularity and patterns, and snoring. So we wanted to just go through all of these with this particular child to see what else could be contributing to the sleep difficulties. If like nighttime awakenings are happening, we want to know as far as what time it's actually happening, how long they're staying awake for, what are they actually doing, because we've had some kids go downstairs and play on the iPad for 2 or 3 hours instead of trying to go back to sleep while their parents are asleep. I've also had another autistic case where they have been having trouble for about a year, but when we really drilled down to the onset of when it started happening, it was last spring when Spring Forward happened, and then the behavioral components kind of compounded and kind of stuck for the full year. So it's very, it's nice to have detailed information about the onset, when it's happening, and how the parents are actually responding when this is happening. Next slide, please. So we want to definitely rule out for any medical comorbidities. In certain cases, you have to think about chronic underlying medical conditions such as asthma, allergies, eczema is a big one that can keep children from falling asleep. If you have any OSA concerns, that would be an indication to refer for a sleep study. And then I've had a case as well for excessive daytime sleepiness. Despite getting like 10 hours of sleep overnight, they're like dozing off and falling asleep. And we did actually find like narcolepsy in this child. So a couple of indications to think about on your differential, than just chalking it up to behavioral incidents. Next slide, please. So despite all of the zebras out there, the most common cause of pediatric insomnia is still behavioral. And there are two big subtypes. One is the sleep onset type, and you will, I think in general pediatrics practice, you always hear about this. My child won't go to sleep unless I rock them. They need to be held all the time. They need a bottle to fall asleep. Some parents go as far as putting their child in a car seat and taking a stroll at like 9 p.m. to get their child to sleep. So there are, so to speak, high maintenance demand kids for sleep onset. And a lot of it has to do with the parenting style. Parents themselves can be anxious, or just the sleeping environment themselves. Like they don't have an extra bedroom for the child, so they're co-sleeping with parents. And some parents get home late and they're in and out of the bedroom, so they're not really getting an ample opportunity to fall asleep. The second subtype is the limit setting type. This is usually the child who is refusing to go to bed, throwing tantrums, doing curtain calls, asking for a snack, and seeking attention. So these are the two subtypes that you want to kind of conceptualize as what's going on around sleep difficulties. Next slide, please. So for these children, we want to try the behavioral strategies first with good sleep hygiene. In the case of the 3.5-year-old, this child was going to bed way past midnight, close to 1 or 2 o'clock in the morning. And you want to set a developmentally appropriate bedtime. For a 3.5-year-old, that would be like between 7:30 and 8:30 p.m. But when this child is sleeping at like 1 o'clock right now, we can't expect this child to fall asleep at 8:30 the very next day. So what you start off with would be what's called a bedtime fading technique. So your temporary goal bedtime would be closer to when this child is actually falling asleep. So we'll set the goal at 1:30 if this child is going to bed at 1:30 for now. And really to minimize the time that they are spending in bed awake. So the goal would be to put that child into bed at 1:30 in the morning and have them achieve falling asleep within 15 minutes of being tucked in. If you're successful with that for about 3 to 7 days, that next following week, you would adjust and pull forward that bedtime to like 12:45 in the morning and go for another 3 to 7 days. make sure that a child is falling asleep within 15 minutes and go forward by 15 minutes every 3 to 7 days until you reach your target bedtime of 8:30. You need to make sure that the bedtime routines are really simple, low key, avoid any high stimulation and electronics or gaming, and be very firm about the ground rules. Bedtime's 8:30, it's going to be 8:30 throughout the week. They really recommend not varying plus minus over an hour between school days and weekends. Visual charts work as well for the younger kids and kids with autism. Next slide, please. The key is to put the child to bed before they're groggy or already asleep. So we want to give them a chance to be able to soothe themselves to sleep. And they are going to throw tantrums. You want to gently remind the child that it is bedtime, avoid engaging in any negotiations or bargaining. Just briefly check in to make sure that you let them know that the parent is there, but don't spend time just trying to soothe or comfort them. If they try to elope from the room, you just gently return them, close the door, but don't lock it, and just peep in every couple minutes to let them know that the parent is actually around. Next slide, please. So positive reinforcements are very, very important in behavioral interventions. So you want to reward these kids with stickers, like praises, favorite breakfast items, and they have a very short attention span. So you want to reward them the very next morning. So it positively reinforces and consolidates their good behavior. There's no need to dig out like that they failed last night or dig up the tantrums that they threw. And just make sure that there's going to be, warn the parents about an extinction burst is likely to happen. And the key is to be consistent and persistent and keep the cool. Next slide, please. Okay. So autism spectrum disorders and sleep is a common topic that comes up. We get a lot of calls about these neuroatypically developing kids and sleep difficulties. It's reported that over 50%, almost up to 75% in some studies, show that these kids have sleep difficulties. And it's pretty evenly split between having trouble falling asleep and just maintaining sleep. It's thought that there may be a little bit of a biological component, having some disrupted melatonin production or circadian rhythm dysfunction, but more often than not, these kids have behavioral insomnia of childhood as well. The American Academy of Neurology published a guideline for sleep difficulties in kids on the autism spectrum in 2020. And they recommend that you want to rule out for any comorbid medical causes, any underlying pain, constipation, any issues or any over-the-counter medications, or some kids have epilepsy and they have other medications that they take as well, and rule out all of those extrinsic causes. But first-line treatment recommendation is always going to be behavioral strategies. Only if you fail or have limited improvement with behavioral strategies is when you consider a low-dose melatonin. Next slide, please. So they looked at the evidence summary for sleep disorders in ASD. They looked at all like behavioral strategies, like and medication options. The only research available to date that has shown efficacy is involving melatonin and melatonin combined with CBT. Interestingly, there wasn't enough evidence for like the clonidines, the antidepressant class medications that we may use, or even Benadryl. So that is to be of note. Next slide, please. So in short, the guidelines on using medications is that there's no medication that is FDA approved for pediatric insomnia. So we're really using these meds if you are off label. It should never be the first treatment choice. Behavioral strategies always come first. And if we do consider using medications, we want to clearly define the treatment goals and make it clear to the family that it's only for short-term use in adjunct to behavioral strategies. For teenagers and older kids, we always want to screen for illicit drug use that may be contributing, and rule out any underlying primary sleep disorders or chronic medical conditions. Next slide, please. So as far as melatonin goes, in the US, we don't really have the long-acting formulation available, but the common properties of melatonin is, one is the sleep-promoting property that most providers use it and target it for. And there's also a second property of shifting the circadian rhythm. Usually it kicks in about 30 to 60 minutes, within 30 to 60 minutes. So I advise parents to give it within the hour of their target bedtime. It has proven to be effective for shortening the sleep onset latency, and also increases the total sleep time by an average of 45 minutes in most research studies. For circadian rhythm phase delay, or like jet lag, so to speak, you can give a very low dose, as low as 0.5 milligrams per day, 5 to 7 hours from the current sleep onset time, which is known to be effective. Next slide, please. For antihistamines such as diphenhydramine or hydroxyzine, I think most pediatricians feel comfortable prescribing this. As you know, the side effects are classic for the anticholinergic side effects. We do want to caution that in some children, especially with neuroatypical children, you want to warn the parents that there is a risk for paradoxical excitation. So it would rather keep them awake and more hyper than what we're aiming for with the side effect profiles. Next slide, please. Another category of medications are the alpha-2 agonist medications, guanfacine or clonidine. This is also being used off-label, and we're targeting the side effect profile for sleep in these cases. The clonidine tends to be a little bit more non-specifically targeting the alpha-2 receptors and tends to be more sedating than the guanfacine relatively. It also lowers the blood pressure and the heart rate, so can present with side effects of like lightheadedness, dizziness. I've had near syncopal events in some teenagers as well who are very sensitive. So you want to be very careful about using these medications and warn the parents about the side effect profiles. And this is not a medication that we recommend using as PRN use. It is meant to be used on more of a continuous basis. And if the family does decide to come off of it, we want to gradually wean them off, because there is a risk for rebound hypertension with abrupt discontinuation. Next slide, please. Other antidepressant class medications for insomnia that you might have encountered specialty mental health providers using are namely trazodone and mirtazapine, or brand name Remeron. These medications do work at a lower dose as a sedative in terms of helping sleep difficulties. We never use it solely for the purpose of that. In many cases, I think our providers decide to use it as an adjunct treatment. The reason they work as a sedative at a lower dose is they have a higher affinity for the histamine blockade. So the higher the dose goes, they will lose that sedative effect and work more as an antidepressant class medication. Namely, trazodone does have a rare side effect of priapism, so you do want to warn patients and families about that. And all of these class medications are antidepressants, so they do have a black box warning on them as well. Next slide, please. So the take-home points are that you want to definitely rule out any underlying medical causes, lifestyle factors, social factors, and sleep hygiene is really important. And behavioral strategies always come first. But if all fails, you can consider augmenting with pharmacotherapy just as short term, but that would not be our first line recommendations. And you need to be aware that these are all off-label use. Thank you so much.
Thank you. Thank you, Jean. We've got a couple questions that came through the chat. Since we've got a few minutes, I'd love it if you could address these. So one of these really is, what is considered low dose melatonin? What's the dose range?
So I think a lot of the new research that are coming out of autism research are recommending starting from 0.5 to 1 even, depending on the age. There's no dose, like a higher dose works better type of a research outcome yet. So we always recommend low dose, 0.5 to 1.
And is there a max length of use recommended for melatonin? How long can they just keep using this? Or
there aren't any long-term studies, so there isn't anything that we know for sure what long-term side effects it may cause. I know we kind of stop between 5 and 10 milligrams. We've seen crazy doses come in like 20 and 30 milligrams in some cases, but there's really no dose dependent relationship. So I wouldn't know what that would really be doing. We'd like to keep it as low as possible and just kind of move around the time of administration to see if that helps at all with the sleep onset.
And in terms of the maximum like number of months or weeks or years, like do we know anything? Or
not at this moment. I don't think there's enough research yet.
Okay. More melatonin questions. Kind of pairing melatonin with like your strategy of like timing the bedtime for when they actually fall asleep and gradually moving it. Could you use melatonin to kind of shortcut that process? So that, and do you have thoughts about that?
I think that would be a strategy. And to our point, our take home point was to be a short term measure, an adjunct with behavioral strategies. So I think that would be an okay idea if the family understood that was our goal.
Okay. Fantastic. Couple more questions, and I think we have like maybe time for one or two more. Do you have like thoughts about like nonverbal kids, autism, like CBT, things like that are like recommended? Like when is CBT like appropriate?
So the CBT that I was specifically speaking to in this article was probably cognitive behavioral therapy insomnia. So there are many different shades of CBT as well. And I'll be very honest, CBT insomnia providers are very hard to come by. So there's a huge access issue, and also CBTI providers for pediatric populations. And if we go into more specifics of neuroatypical children, that might be even more difficult to find. But the 5 pillars of CBT insomnia is like the first step is sleep hygiene education, which most primary care providers are doing already. The second pillar is going to be stimulus control in terms of reconditioning this child to bed equals sleep. Nothing else happens in the bed. And we're just really cutting out any type of stimulation, like no gaming in the bed, no reading, no doing homework, no worrying in the bed. And if you can't fall asleep within 15 minutes, you get out of the bed. So you dissociate like being awake from staying in your bed. So that part you're already doing as well. The sleep restriction piece is probably what I talked about with the sleep fading. So if you can coach these parents and families to like start with when they're actually falling asleep as their temporary bedtime and kind of slowly moving that time up by 15 minutes every 3 to 7 days to get them to their target developmentally appropriate bedtime, you're already doing the third pillar of the CBTI. And then working on like some relaxation techniques, like with breathing, like guided imagery would be the fourth pillar. And then for older kids who are a little bit more verbal, we use the cognitive strategies. Sometimes some kids will worry about themselves not being able to sleep, or worry about tomorrow, what's going to happen tomorrow. And that's where the traditional cognitive behavioral therapy model kicks in to reorient these children. I hope that helps, but you can easily do the first 3-4 steps just by educating and working with the parents.
Thank you so much. There are some fantastic questions here that we won't have time to get into regarding culture and sleep. That I think is a much longer discussion. But the very last one is maybe straightforward is if you're giving over like a milligram or two of melatonin, do you have to taper down a melatonin dose or can you just stop it?
There's no research on that in terms of withdrawal side effects. So I think generally most families just self-discontinue if they feel like it's not working, and we haven't really seen an adverse effect anecdotally. And in research, there hasn't been any mention of it being dangerous to do. So I think it would be fine for now.
Fantastic. Thank you so much, Jeein, for the great talk. I know we all learned a lot. We'll be sending out your handout later to this entire group.